The exhaust valve in the ventilator allows driving gas to exit the bellows when open. The spill valve allows excess gas from the ventilator to escape into the scavenging system. There are two types of ventilator systems. The first type of ventilator system is the bellows system. Bellows move up and down to drive pressure through the anesthesia machine. Piston ventilators are mechanical. They don't use bellows, but work more like a motor. The bellows system is different than the piston system. There are ascending bellows which ascend during expiration, and they descend during inhalation. When the circuit is disconnected, the bellows will collapse. The reservoir bag is part of the ventilator circuit during mechanical ventilation, but not the bellows system. It can be filled with oxygen and used to provide positive pressure. Pneumatically driven bellows fill with the patient's exhaled gas and fresh gas flow. Excess gas is vented to the scavenging system. The scavenging system will lose pressure if the circuit is disconnected. Refill by increasing O2 flows, fresh gas flow compensation, and fresh gas decoupling. Fresh gas compensation means to prevent the fresh gas flow from affecting the tidal volume by measuring the actual tidal volume and using this information to adjust the volume of gas delivered by the ventilator. Fresh gas decoupling aims to prevent the fresh gas flow from affecting the tidal volume by isolating the fresh gas flow so that it does not enter the breathing system during inspiration. Ventilation describes elimination of CO2. Oxygenation describes intake of O2. Under normal, spontaneously breathing conditions, an adult male will consume oxygen at a rate of 250 milliliters per minute. The production of CO2 is around 200 milliliters per minute. 200 divided by 250 equals 0.8, which is where we come up with the respiratory quotient. Minute ventilation equals alveolar plus total dead space ventilation. Physiologic dead space is 1/3 of the total minute volume. During positive pressure ventilation, under anesthesia, the total physiologic dead space increases to 45% of the tidal volume. Work of breathing, or WOB. The work of breathing is the sum total of the work related to overcoming the elastic properties of the lung and chest wall, and the work related to overcoming resistance. The whole purpose of the ventilator is to perform the work of breathing. The two distinct impedances that have to be overcome by the ventilator include compliance and resistance. Compliance is the ratio of change in volume to change in pressure, in liters or milliliters per centimeter of water. Resistance is the ratio of change in driving pressure to the change in flow rate, in centimeters of water per liter per second. Compliance refers to the properties of the lung and chest wall. Resistance is talking about the endotracheal tube, the breathing circuit, and the conducting airways. Without overcoming compliance and resistance, we don't have inspiratory flow. Normal static compliance, 35 to 100 milliliters per centimeter of water. Pediatrics, greater than 15. Peak inspiratory pressure is the maximum pressure in the patient's airway during inspiration. Anything that increases resistance will increase the PIP. PIP is more of a reflection of resistance. Normally want around 20 centimeters of water or less. Of RDS, large body habitus, high insufflation pressure, steep Trendelenburg, all equally cause high resistance and increase PIP. PAW is mean airway pressure. Mean pressure applied during positive pressure ventilation correlates with alveolar ventilation, arterial oxygenation, and hemodynamic performance. PAW is determined by PIP, the fraction of time devoted to the inspiratory phase, and PEEP. PEEP is positive end expiratory pressure. It is a constant amount of pressure is maintained in the airway throughout the expiratory cycle. It improves oxygenation by preventing collapse of alveoli. It helps to prevent atelectasis. General anesthesia causes alveolar collapse, absorption atelectasis, compression atelectasis, loss of muscle tone, decreased FRC, and decreased closing capacity. Optimal PEEP. Under general anesthesia with PPV, ventilation is directed to low-resistance airways, while high-resistance, less compliant airways receive inadequate gas exchange. Optimal PEEP is determined by gas exchange, hemodynamics, surgical procedure, and positioning. Monitor compliance with changes in PEEP, increasing or decreasing in increments of 2 centimeters of water. Intrinsic PEEP, usually a bad thing, also known as auto-PEEP. Pressure generated by trapped volume in the airway at the end of expiration. A common issue in patients with obstructive pulmonary disease. Noticeable on the flow tracing. If the flow starts from a negative value at end expiration, this is a sign of auto-PEEP. Decreasing the respiratory rate and increasing the IE ratio will help decrease auto-PEEP. Intermittent vital capacity maneuvers, recruitment maneuvers. Inflating the lungs to 40 centimeters of water for 7 to 8 seconds can re-inflate collapsed alveoli. Driving pressure. The difference between PLAT and PEEP. The ratio of tidal volume to compliance. High driving pressures, greater than 13 centimeters of water, are related to post-operative pulmonary complications. RAW. Airway resistance gives objective data to consider during mechanical ventilation or in diagnosing airway compromise, calculated as pressure per unit of flow per unit of time. RAW equals P, IP, minus P, PLAT divided by flow, in liters per second. Optimal RAW is less than 10 centimeters of water per liter per second. Airway resistance and inspiratory flow are more intertwined than you would think. The highest flow and speed set to deliver a tidal volume happen during inspiration. Higher flow rates mean faster delivery and shorter inspiratory times. Dead space accounts for 33% of each breath that does not participate in gas exchange. That is about 2 milliliters per kilogram of ideal body weight. Anatomical dead space plus alveolar. Dead space equals total dead space. I to E ratio is the ratio of inspiratory time to expiratory time. The I to E absolute times are determined by the duration of the respiratory cycle, set by the frequency. When a breath switches from inspiration to expiration, that is one cycle. If you set the tidal volume to 600 with an I to E ratio of 1 to 2, this will equals an inspiratory flow of 18 liters per minute. An I to E of 1 to 1 increases the inspiratory time to 3 seconds, but the net effect is actually an inspiratory flow rate of 12 liters per minute. Use this with really sick patients who you don't want to expose to too much oxygen. I to E 1 to 3 equals 24 liters per minute. Lung pressure relationships. Peak inspiratory pressure reflects both airway resistance and lung compliance. Plateau pressure isolates the elastic component. The difference between PIP and plateau is your airway resistance. Keep plateau below 30 centimeters of water to avoid barotrauma. Ventilator waveforms are pressure time waveforms let you visualize compliance and resistance at the bedside. A square flow waveform produces a characteristic pressure rise. Decelerating flow waveforms distribute gas more evenly and reduce peak pressures, generally preferred in lung protective ventilation. Alveolar recruitment is used when collapsed alveoli are reopened by sustained elevated pressure. The goal is to shift the lung to the open, compliant portion of the pressure-volume curve. Once recruited, PEEP is used to maintain alveolar patency and prevent derecruitment. Lung protective ventilation is the cornerstone strategy for all mechanically ventilated patients. Tidal volume 6 to 8 milliliters per kilogram of ideal body weight. Plateau pressure below 30 centimeters of water. Driving pressure below 13 centimeters of water. PEEP titrated to maintain recruitment without overdistension. Ventilator mechanics and pulmonary physiology are inseparable. Every parameter you set, tidal volume, rate, PEEP, flow, has a direct physiologic consequence. Understanding the pressure relationships, compliance, resistance, and dead space gives you the framework to troubleshoot any ventilator situation with confidence.